I want to thank everyone for joining today's webinar. My name is Alex Chan, and I'm currently the chair for the Department of Clinical Pharmacy Practice at the School of Pharmacy and Pharmaceutical Sciences at UCI. Now, since February this year, UCI School of Pharmacy and Pharmaceutical Sciences has launched a series of webinars with the goal to educate the community about the vaccines and to provide evidence-based information as well as promoting the safe use of these vaccines in our community. So counting fingers, we're actually coming to the fourth installment for the series, by the end of this year. And we've been providing timely updates related to the vaccines. Now, as the vaccines are starting to be administered in more populations, including pediatric, I thought it's actually timely for us to bring on our school's strategic partner, which is the Children's Hospital of Orange County, or CHOC, to co-host the webinar with us. So here it gives me great honor to introduce our co-host, Grace Megaman, who is the Executive Director of Pharmacy Services at CHOC, a 334-bed hospital, and she has served for CHOC for more than 15 years. Passionately and positively driving optimal medication management and pediatric patient safety through innovation and process improvement. So let's welcome Dr. Megaman.
Thank you so much, Alex. And thank you for inviting CHOC to co-host this community information session with UCI School of Pharmacy and Pharmaceutical Sciences. We're also honored to collaborate with you. Our first speaker will be UCI Associate Clinical Professor Li Wen, who is an infectious disease pharmacist with a passion for antimicrobial stewardship and pharmacy education. Next, we'll have my colleague from CHOC, infectious disease pharmacist Tuan Tran. Tuan's focus is on quality improvement in antimicrobial use and resistance across healthcare settings. He has a passion for optimizing anti-infective pharmacokinetics and pharmacodynamics in children. Following Tuan will be Sean Griffin, who is a health sciences assistant clinical professor at UCI. Sean has worked as an oncology pharmacist and a clinical pharmacist in hematology, stem cell transplant, and immune cell therapy. And last but not least, our final speaker will be Carrie Hurley Kim, also a health sciences assistant clinical professor. In addition to her role at UCI, she also serves as vice chair for the steering committee of the Immunization Coalition of Los Angeles County. Let's get started.
Hello, everyone. Today, I will be talking about updates and recommendations, as well as vaccine effectiveness. Next slide, please. So this first slide talks about the current recommendations. As you can see, the vaccines are recommended for anyone above the age of 5, and only those 18 years and older can receive any of the 3 types of vaccines. Next slide, please. And so this is the current recommendations for boosters. So the newest recommendations is for everyone 16 and 17 years of age to receive a booster at least 6 months after completing the primary vaccination series. And the booster type pertains only to the Pfizer, versus everyone 18 years and older that received either Pfizer, Moderna, or Johnson & Johnson can receive any of the other vaccine types as a booster. Next slide, please. So this slide talks about vaccine effectiveness. There's a lot of numbers in here, but it's okay. It talks about how effective the vaccines are in preventing hospitalizations. And this is the data from January to September of this past year. And you can see it's broken down by those who are 18 years and older who are immunocompetent, as well as those who are immunocompromised. In general, you can see the vaccine effectiveness is roughly 90% for those who are immunocompetent and about 77% effectiveness for immunocompromised. You can see the overall numbers for those who are vaccinated are roughly 4% positive for COVID over this past 9 months. Next slide, please. If you look at it a little further in terms of comparison in terms of vaccine effectiveness broken down by age group, you can see that those over the age of 65 in the right-hand column are roughly 87%, 75%, which are relatively lower in comparison to those who are relatively younger at 18 to 64 years of age, who have about 93% effectiveness and an 80% effectiveness for those who are immunocompromised in terms of preventing hospitalization. Next slide, please. So this is the slide from the CDC that talks really about the incidence of COVID cases based on vaccination status. As you can see, those who are unvaccinated in the black line, you can see that it really peaks there in terms of overall in comparison to those who received a vaccination that's either Janssen, Pfizer, Moderna, which is relatively low. Next slide, please. So the rates of COVID deaths based on vaccination status, as you see, being fully vaccinated is very protective in comparison to those who are unvaccinated. These rates, nearly increased to nearly 20 cases per 100,000 in the population. And during our last surge, you can see that it really peaked there. Cam, the next slide, please. So this slide is also a quite busy slide, so we're going to take it a little bit slower. So this is the data that really supports, getting the booster shots. As you can see from the top line, the top red arrows, it talks about documented infections. And after 127 plus days, the overall vaccine effectiveness actually decreased in comparison to the early stages after completing the first series. But in terms of severe disease or hospitalization or death, you look at the bottom two arrows, you can see it initially was roughly 89%, and it has decreased slowly to 87% over time. So we do see some waning of our immune response secondary to the booster shots. And this pertains to the Pfizer vaccination. And then next slide, please. This is the slide that pertains to the Moderna, and it's very similar in terms of after 120 plus days, you can see it decrease from the 94% to 77% in terms of documented or symptomatic infection. It has that decrease over time. And on the bottom red arrows talk about severe disease and hospitalization and death. Again, after 120 plus days, it did decrease a bit from 92% to about 88% overall. This is one of the rationales behind giving a booster, to really pump up the immune system in everyone so that it goes back into the higher percentiles. Cam, the next slide, please. And so this is the outcomes data that's seen in Israel in terms of the booster shots. In Israel, they have roughly over 800,000 patients who actually got a booster, and they really compared the mortality due to COVID in comparison. And the blue line on the bottom talks about the mortality rates in comparison to those who did not receive a booster. And patients who received a booster were 90% lower in terms of rates of mortality in comparison to those who did not receive a booster. And so it's not a huge number, but it's actually still beneficial in terms of why we want to get a booster. We have the data that talks about waning antibodies as well as overall efficacy of like the outcomes we're looking for, such as reducing hospitalization and reducing death. Cam, the next slide. So I think the main take-home message is to get vaccinated if you're not vaccinated. Get a booster when you're eligible, because you can see the potential benefits of reducing hospitalization and reducing death. Wear a mask to minimize exposures to those who are at risk, who can't get vaccinated. And keep up the hand hygiene. Soap and water and alcohol gel will really help minimize these little things that may transmit it. And thank you. I'd like to introduce the next speaker, is Dr. Tuan Tran from CHOC Hospital.
Thank you, Lee, for a very informative presentation there. And again, thanks, Grace, for the introduction. My name is Tuan. I'm the ID pharmacist here at CHOC. The next couple of minutes, I'll just share with you some of the epidemiology that we see in pediatrics, as well as the vaccine efficacy and some of the side effects that you can potentially anticipate. Next slide, please. Next slide. Okay, so I just start off with this slide here because I think it's illustrating important points, because I think sometimes in the news media we tend to take it that we don't see pediatric cases, but here what you see here is this number is actually increased now. It's close to 7 million pediatric cases, and this data from the CDC. So roughly about 17%. And the next slide, please. Now, if you zoom in a little bit, obviously, certainly the cases are mostly in adults. At the bottom right hand, you can see that the pediatric cases is actually increasing. So it's now account for up to somewhere about 2 to 4% of all COVID cases in the US. Next slide. And this slide here is data, again, from the CDC, and we do see mortality in pediatrics. And you can see the range here. Often we see the very young infants, and tend to be the older, sort of the adolescent children and teens that account for the major deaths. Next slide, please. The other thing that I just want to touch base really quickly is what's known as multi-system inflammatory syndrome in children, MISC, because this is sort of an entirely new entity that we've seen with COVID, and it's some of the most complicated, some of the most critically ill patients we've seen compared to many other sick patients that we have seen at CHOC. So MISC is a very rare, very severe inflammatory condition, It typically occurs somewhere 2 to 6 weeks after an acute infection from COVID. And as of late last month, there's almost 6,000 cases that has been reported to the CDC. And the median age, as you can see here, about 9 years old, but the children from the 5 to 11 age group makes up almost half of all the MIS-C cases in pediatric. And the majority, about 70% of these cases ended up in the ICU, and I'll pick you. And as of this data, report this data, there's been about 52 reported deaths, pediatric cases. Next slide, please. And so this data here, so we just take a little bit of zoomer closer to this is California. So this CPH data, CDPH data. So you can see, the proportion of adults has dropped, whereas the pediatric in the upper portions in the red and the tan there is increasing. So it's account for close to 30% of all COVID cases now. This is, again, just California data. Next slide, please. And I just want to share with you a little bit of what we've seen at CHOC. So at CHOC here, just since the beginning of the pandemic, we've tested about 46,000 patients, and about 13% of those have been positive, or close to 6,000. And this data is updated as of the beginning of December. And we've seen about 11% of those patients were hospitalized. The vast majority of pediatric children do very well. We typically test them and we discharge them. But there are 11% of them do get admitted. And on the right side, the top right-hand side, you can see the hospitalization by age group. So again, what I just want to point out here is the very young, so the young infants do get admitted, and then the older ones, so sort of the adolescent, bigger teens, whereas the 1 to 5 and the 6 to 10 in the orange and the blue, they don't seem to get, they do very well. I mean, even when they do get hospitalized, they do seem to do much better than the very young or the very old, older teens. And then if you sort of take into another step further into more granular data and look at those patients that get admitted into our ICU, the very sick one. So what you see is interesting, because now a lot of these ICU patients tend to be older patients. And the reason I want to point this out is because all of these, the patients that get admitted are actually the vaccine eligible patients. And I'll go to that in the next couple of slides. Next slide, please. So, and this data, this slide is from a recent ACIP meeting, which is the advisory committee to the CDC. And so they discuss the COVID vaccine as relative to some of the other vaccines that we've been giving to children for many years now. So, for example, chickenpox, the NMR vaccines, that's almost required for by most of the states' public school. So the top part you can see is the hospitalization per year prior to recommended vaccines being available. And then on the far right-hand side, you can see COVID-19. And this is data up until October. So before we had vaccines authorized for the pediatric patients, 5 to 11 years old. And the bottom is the number of deaths, again, per year prior to the recommended vaccines being available. So if you look at these data, I think it brings you into perspective that COVID vaccine is really now a vaccine preventable disease in children, because now we do have a very effective vaccine. Next slide, please. So just in terms of efficacy, so I'm just going to talk about the Pfizer-BioNTech, the mRNA vaccine, because that's really the only one that has been authorized for pediatric. So the orange cap is the authorized down to children 5 and up to 11 years old. The purple is for 12s and older. There's 2 doses, about 3 weeks apart. Now the dosing is about a third for the younger children, 5 to 11 years old. And some of the other common questions I just want to address here is the dose should be given regardless of size or weight. And if the child happens to change age in between when he or she got the first dose versus the second, they should get the dose based on the child's age on the date of vaccination by CDC recommendation. And it's really the child should get the vaccine regardless of the history of SARS-CoV infection or whether they have been previously seropositive or not. And you can administer, because of course we are in the midst of a flu season as well, we can administer the COVID vaccine with influenza vaccine. And then as Dr. Lee has pointed out, or Dr. Nguyen has pointed out, just last week, the FDA authorized the booster dose now down to teens or older teens, so down to 16 years old and up. Next slide, please. So efficacy. So the vaccine has been phenomenally effective. I think that's something that we certainly hope for, but so you can see here that just very briefly the data. So, their study included roughly about 3,000 patients, and this is actually very standard for vaccine trials. It's included over 90 trials in over 4 countries. The mean age is about 8 years old. 20% of these child has coexistent conditions, most commonly obese, chronic lung disease, and they will follow for more than 3 months. And you can see that the vaccine efficacy for the younger children, it's 91% and almost up to 100% in the older kids. So it's phenomenally effective against confirmed symptomatic COVID disease. Next slide, please. And in terms of antibodies, so I just want to share this really quickly. So as you can see here, the 5 to 11 years old get the smaller dose, as I mentioned, the 10 microgram. And that's because it induced very similar antibody, neutralization antibody response, very similar to the adults. So you can see the numbers there are very similar. And it's the same for the older 12 to 15 years as well. So the other common questions we often see is, should my child still get the vaccine if they have tested positive? And yes, and I think the answer, the quick answer is yes, because in the trial, almost 10% of the children were seropositive. And what we found is that they actually had higher post-vaccination antibodies and a lower reaction, both local and systemic reactions. And the vast majority of children, as I previously mentioned, they tend to have very mild and asymptomatic infections. But what's interesting is, and there's still a lot that we don't fully understand, is that these particular patients seem to have a higher incidence of MIS-C, which is that very severe inflammatory condition that I previously mentioned. And this second entity that we're still finding out more, which is often known as post-COVID conditions. Next slide, please. So this is sort of the adverse effect that you can expect. So I just want to share this because the vast majority tend to be mild and local. So this is comparing the Pfizer-BioNTech, post dose 1 on the left-hand side and then following dose 2. Most of them, so you certainly will see higher than placebo, but the vast majority of very mild local reactions, redness, swelling, and pain, and it's typically lasted roughly 2 days. Very few systemic events, and if it does happen, they tend to have fever, fatigue, chills, and it's more common after dose number 2 than dose 1. There were no anaphylaxis, no myocarditis reported during the trial, and no major serious adverse effect, meaning no life-threatening hospitalization, etc. And then you can see the percentage that reported there in compared to the older cohorts, adults 16 and 55 years old. Next slide, please. So I just want to touch base really quickly about myocarditis because there's some very interesting data that just released. And so this particular study compare the classic myocarditis. So myocarditis is inflammation of the heart tissues. So classically, it's typically induced from a viral cause. And they compare that with MIS-C. So myocarditis can certainly happen with MIS-C. In fact, it's way more common than from the vaccine-related myocarditis. So this particular study compared the cases of all of these patients. So what you see here is the myocarditis from COVID-19 vaccines are very mild and moderate, which is the far right hand there. And you're looking at, so there's at discharge and at 3 months follow-up. So almost nobody had really had required medication, the treatments. And typically the onset's about 2 days and 91% of the time it's after the second dose. But some of the symptoms that you can look for is chest pain. If the child complains of chest pain, shortness of breath, that certainly should be a clue. And the risk of myocarditis, as I mentioned, it's about 16 times higher with a COVID infection than those without. And if you look at pediatrics younger than 16, that number actually goes up greater than 30 times, and very similar for the elderly, greater than 75%, greater than 5 years old as well. Okay, so this slide here is in weighing. So at the deliberation from the ACIP last month, in weighing the benefits, the balance of vaccine benefits to the risk of potentially any complications from getting the vaccine. And so I just want to share this here. So on the left-hand side, they compare with the recent epidemiology. So because of including Delta, because as I shared previously, is that the number of pediatric cases has been increasing. So you can see there for the benefit for every 1 million vaccination in children 5 to 11, we can prevent almost 60,000 cases, over 226 hospitalization, and 132 MISC cases, as well as 72% ICU admission. Now, if you look on the right-hand side, because of course, if we looking at the history of COVID is sort of, there's peaks and troughs. So if we flatten all of that out and consider a pandemic average for every million doses, we can still prevent about 19,000 COVID cases and 80 hospitalizations, and then 26 ICU admission. And so, all of this taken together, I think that the benefits of the vaccine in this children age group still outweighs any potential side effects. And hence that led to the authorization for the vaccine use in that particular, down to children age 5 and older. And next slide, please. And this one, I just want to share with you, although the trial only included by 3,000, but this is data recently from early this week. And you can see that, more than 5 million doses have been given to children 5 to 11 years old, and close to 20 million doses have been given to pediatric patients. On the left-hand side, this is CDC data and US data. And if you look at the Orange County data, and you can see there, we up to almost 500,000 doses. And so in the pediatric age group. With that, we'll pass it on to the next speaker. Thank you.
Thank you for that very important information in the pediatric population, Dr. Tran. Over the next few minutes, I'll take a step back and look at sort of an update on overall vaccine safety in the population as a whole. Over the past year, there have been hundreds of millions of doses of the vaccines given in the United States, and I'll present some of the safety data that we've learned through all of those administrations. Next slide, please. I think many of us are definitely aware of the most common adverse reactions. These are adverse reactions that can occur in greater than 80% of patients and often occur within hours to days of receiving one of the COVID-19 vaccines, and are often very mild and self-limiting. They can include, as you see here, injection site pain, fatigue, headache, muscle pain, chills, joint pain, fever, and swelling around the site of injection. Next slide, please. But there are also some serious adverse reactions that thankfully are very, very rare. The information that I'll be discussing here comes directly from the CDC's Vaccine Adverse Event Reporting System, and the information is current as of the last week in November. There are 5 rare but serious adverse reactions that the CDC highlights that I want to talk a little bit more about. The first 2, anaphylaxis or allergic reaction, and Guillain-Barré syndrome, or damage to some of the nerves as the result of immune activation from the vaccine, are 2 rare but serious adverse reactions that have been described and associated with many vaccines over the past several decades. These 2 side effects, or the incidence of the rare but serious adverse reactions of anaphylaxis and Guillain-Barré syndrome with the COVID-19 vaccines, are lower or similar to other commonly utilized vaccines, such as the flu vaccine and the TB vaccines. I do want to focus in the context specifically of COVID-19 vaccines a little bit more on the last 3 rare but serious adverse reactions listed here. Next slide, please. The first one that has been heavily covered over the past year in the media is thrombosis with associated thrombocytopenia. This is a particular syndrome that affects the blood, where a patient is at an increased risk of both blood clots as well as bleeding at the same time. And it's most commonly associated with those patients who receive the J&J vaccine. In fact, of the more than 14 million doses of the J&J vaccine that's been administered, there have been 44 confirmed reports of people who later developed this syndrome. And unfortunately, there have been a handful of patients that just died as a result of this complication after receiving the J&J vaccine. And women younger than 50 years old should be especially aware of this potential risk if they were to receive the J&J vaccine. And it's interesting because you may have seen that over the past 24 hours, the CDC has actually taken the stance that the J&J vaccine, at least in adult patients, is no longer one of the clinically preferred vaccines. And this is in part because of this potential risk, as well as a review of some of the efficacy information. So while this vaccine is still available for adults who can't receive or don't want to receive one of the mRNA-based vaccines, it should be noted that the CDC's preference is that patients receive one of the mRNA vaccines over the J&J vaccine at this point in time. But even if we look at the risk of thrombosis with associated thrombocytopenia, it is still exceedingly rare, with fewer than 3 cases reported per 1 million doses of the J&J vaccine that have been administered so far. Next slide, please. The next side effect I wanted to talk about is myocarditis and pericarditis. Dr. Tran did a great job of looking at this particular side effect in pediatric and adolescent patients, but I wanted to provide some context for the overall population as a whole, with a lot more of adult patients included in that mix. Of the nearly 460 million vaccine doses that have been administered, there are right around 1,000 confirmed cases. Certainly in those younger patients, particularly adolescent males, there is a slightly higher risk. And most cases have been reported with the mRNA vaccine versus one of the other vaccines like the J&J vaccine. But still, in the population as a whole, it is an exceedingly rare adverse event with less than 2 cases reported per 1 million doses administered. And of those 1,000 cases, in those patients who ultimately needed to be admitted to the hospital, a large percentage, greater than 3/4 of those patients, were able to be discharged within 2 days. And all of the patients who were ultimately admitted to the hospital for myocarditis were discharged from the hospital. Next slide, please. And then the final sort of adverse event that is highlighted on the CDC's website and certainly has been talked about in the media and certainly on social media is death after COVID-19 vaccination. And while there have been over 10,000 reports of death after COVID-19 vaccination, as indicated through the CDC's website, it is important to note that healthcare providers are required to report any death to the CDC, even if it's unclear whether the vaccine was the cause of that death. And in fact, when a large panel established by the CDC looked at a variety of different medical records, including autopsy results, medication records, and additional available records, they were unable to find any causal link between one of the COVID-19 vaccines and death after vaccination. But even if we don't accept that, or we're skeptical over that, it's still a very, very rare potential side effect, with fewer, or right around 22 per 1 million, or 22 cases reported per 1 million doses of the vaccine that are administered. Next slide, please. Now, looking specifically at these adverse reactions after receiving a booster dose, so a 3rd dose of one of the mRNA vaccines, the rates of common adverse reactions, as well as those rare but serious adverse reactions, are similar in that 3rd booster dose as they were and as patients experienced after the 2nd dose of an mRNA-based vaccine. The information presented here is specifically for the Pfizer vaccine, but it is also very similar for the Moderna vaccine. And to date, there have been no unexpected patterns for the booster dose in particular compared to the standard doses of these vaccines. And there's been no increase in those rare but serious adverse reactions that I've talked about when compared to other doses of the mRNA-based vaccines. Next slide, please. And I think it's important to put these rare but serious side effects into context. So the vaccines that we have available are very, very effective at preventing severe COVID-19 infections. And part of the reason why this is so important is because of some of the clinical consequences of a severe COVID-19 infection are listed here. And looking specifically at complications that are similar to those rare but serious adverse events with the vaccine that we talked about, you can see that the incidence with severe COVID-19 infections are thousands, if not tens of thousands of times higher with patients who receive or who were to experience a severe COVID-19 infection versus those who might experience a rare but serious adverse event after receiving one of the COVID vaccinations. Overall, I think it's extremely important because of this information to receive one of the COVID-19 vaccinations or a booster shot if you're eligible. Next slide, please. And similar to some of the information that Dr. Tran presented in the pediatric population, there is still a benefit to getting the COVID-19 vaccine, even if you have a history of getting COVID-19. The vaccine in these patients who already had a primary case of COVID-19 has been shown to still provide additional or a boost in protection against a second COVID-19 infection. And there's still a benefit to getting the vaccine, even if you've had a COVID-19 infection. Next slide, please. And with that, I'd like to turn it over to our final speaker, Dr. Carrie Hurley-Kim.
Thank you so much, Sean. So I'm going to just be wrapping up with a discussion of some of the public health implications of the vaccinations and kind of where we are now in the pandemic. I will also be talking about the new Omicron variant and some of the early available data that we have at this point. Next slide, please. So just to kind of give an update, I've used this slide and updated the numbers, I think, in most of the talks that we've done in this series, but I just want to highlight that we continue to have really significant racial and ethnic disparities in our vaccination rates in the United States, and the same holds true in California and locally here in Southern California as well. We can't really compare these geographic regions apples to apples because the way the data was collected is a little bit different, and the type of data that was collected was a little bit different. But what we can see is that there is a very strong, consistent pattern of lower vaccination rates, particularly among our Black and Latinx community members. We also have significant socioeconomic and age-related disparities. I think it is important to note, though, that vaccine rates are increasing, and we do see now about 20% of our young children having received at least one dose, and this has just been since right around Halloween that the vaccine was available to those young kids. So we are making progress, but we do have some gaps and we do have a ways to go. Also important to note that about 30% of the adults who are vaccinated have received a booster. And this is a pretty strong result, given that not every vaccinated adult is yet eligible to receive a booster. Next slide, please. Globally, we are not doing as well. So you can see here the really significant disparities between our upper or higher income countries and particularly our low income countries. We're seeing really fast growth in vaccination rates right now in our middle income countries, particularly our lower middle income. But I think it's really important that we acknowledge and understand the risks associated with this very low vaccination rate in our low income countries. I will say that we have pretty strong evidence to suggest that the Omicron variant originated in one of these low income countries. And I think we have low vaccination rates and our, just to say it bluntly, our failure to assist these lower income parts of the world to thank for the rise of new variants. Next slide, please. So moving on to the variant, what's been in the news and I think on everyone's mind. So I'm going to talk a little bit about what we know, and unfortunately what we know is not a lot. What we're still learning is the bigger piece here. So We do know that the Omicron variant was first reported right the day before Thanksgiving and almost immediately was designated as a variant of concern. Looking back retroactively at samples that had been collected previously, there was a sample found that had been collected on November 9th, which is the earliest known specimen at this time. I think it's also important to note that that specimen was not taken in South Africa, so it was taken in a neighboring country. The virus happened to be identified in South Africa because the infrastructure there for testing is much stronger. What we also know about the variant is that it has a lot of mutations, and this is why this variant is so concerning. A lot of those mutations are present on what's called the spike protein, which is the target of our vaccines and also a lot of our therapies, and is believed to be the reason that we are starting to see evidence for a lower efficacy of the available vaccines that we have today. The variant has been detected at this point in about 80 countries and well over half the states in the United States, although not every country is testing for variants in the same way. So I think it's pretty safe to say that this variant is present worldwide at this point. The Delta variant does continue to remain dominant both here in the US and worldwide, but the Omicron rates are rising really, really quickly. And we do have reason to believe that Omicron will become dominant within the next month or two. Important to also remember that the things we've been doing all throughout the pandemic continue to be important and effective. So we have no reason to believe that masks are less effective, that social distancing and things like effective ventilation and holding, meetings and gatherings outside when possible and in small groups, all of those things will continue to be important as we go forward. Next slide, please. All right, so moving on then now to what we're still learning, and this is a lot. This information is changing almost on a daily basis. We don't know the exact location of origin for the Omicron variant, and we don't know the true global spread, although we're becoming, and I'm more and more confident that this is kind of a moot point at this time because it's very likely that we're seeing worldwide spread. We also are pretty comfortable that our diagnostic testing continues to be effective. And this is really good news because we can continue to use the tests that are available and they are detecting Omicron cases. We're not seeing higher rates of false positives and false negatives. Transmissibility is a big question mark. We do believe that Omicron is significantly more transmissible than Delta, but the big question is how much more transmissible? Is it 2 times more, 4 times more? We're not 100% certain exactly the number here. Also with the severity of disease. So this has been in the news a lot. I think people are very quick to look for a little bit of comfort in the fact that this variant may cause more mild disease. And I think it is fair to say that. However, we need to think about the magnitude of what that means. So there was a large study of insurance data in South Africa that found a 29% lower rate of hospitalizations, which is a good thing on a case, from case to case. But with a virus that's more transmissible, having a slightly lower rate of hospitalizations still means that we could have, increased and, potentially devastating strain on our healthcare systems. Next slide, please. Another thing that we are still learning more about is immune escape. So how effective are vaccines? How much protection does prior infection provide? And for both of these things, we believe the answer is somewhat or significantly less compared to Delta, and especially compared to the original SARS-CoV-2 strain. So with prior infection, what we're actually seeing is a higher rate of reinfection compared to other variants. So in the past, we could be pretty confident telling patients that for 3 to 6 months after an infection, it is unlikely that you'd be reinfected. I think we need to kind of adjust our thinking on that and be a little bit more insistent with patients who have had a previous infection that vaccination early after that initial infection is still incredibly important. In terms of our vaccinations, we're starting to have information that suggests that a primary series, meaning, for example, 2 doses of an mRNA vaccine is quite a bit less effective than that vaccine against Delta, although our boosters seem to be providing significantly more protection than the 2-dose series. So I think this makes boosters really important. And there's even some discussion now of whether or not a quote unquote complete vaccine status will mean a 3-dose series at some point in the future. Our effectiveness of our treatments is also another kind of open question. So there is evidence that the monoclonal antibody treatments that we've been using in our sicker patients to treat especially Delta in the recent past are going to be much less effective. And this is because they work very much in the same way that the vaccines do. They target that spike protein, and when there's less of a match, they tend to be less effective. We do have some promising laboratory results, though, with a drug called Paxlovid, which is an oral medication that works somewhat similarly to some of our HIV antivirals and has a completely different target than the spike protein. So this drug, we do believe, will maintain at least some high level of effectiveness against Omicron. Next slide, please. So just to kind of put this all into context, so there's a lot of things that seem to be promising information and things that are really scary pieces of information. So on the positive side, we do have a lower risk of hospitalization. We think that some of these infections may be less severe. Also, I think it will be really game-changing if we're able to have an oral effective antiviral medication. Pfizer is in the process of applying for and obtaining emergency use authorization for that medication. Next slide, please. But I think we need to be careful not to assume that those positive things will outweigh some of these more concerning aspects of the variant. So increased transmissibility, our ineffective global vaccination strategy, having a lower efficacy of our vaccines, and the increased risk of infection, I think are all more than enough to outweigh the quote unquote benefits that we might receive from those other 2 things. And then I put the higher effectiveness of boosters kind of to the side as a plus or minus. I think on an individual level, this is absolutely a positive thing. I feel pretty confident that the booster I've gotten is going to provide me personally with good protection, but I am concerned that as we start using more and more boosters, especially in the developed world where we already have higher vaccination rates, that this is going to continue to strain and delay effectively vaccinating the lower income parts of the world and potentially contribute not just to the increasing spread of this variant, but also to the potential for the next variant that may be coming. Next slide, please. I think that might be it. Okay. So just another important note, if you're in California, the vaccine appointments are freely available. Most local pharmacies are offering them, and pharmacists are now administering the majority of COVID vaccines in this country. So I think we owe a big thanks to our community pharmacy colleagues as well.
Thank you, Dr. Hurley Kim. And I do agree. We do owe a lot of the healthcare professionals who are really dedicated a lot of time vaccinating our community. And without them, we won't be able to get so many people vaccinated. But we need more. We certainly need to continue to spread the word about these vaccines. I do see that there are quite a few questions that came in. And I thought maybe we can spend the next 14 minutes that we have to address some of these questions. And feel free to continue to send your questions out through the live chat. And then I'll get the speakers to address them. So this is the first question, and I think maybe I'll have Dr. Griffin to take this question. The question is, from my understanding, the highest rates of myocarditis occurs in younger males after the second dose. Is there current post-booster myocarditis risk data available, especially for younger males at this time? What are your thoughts, Dr. Griffin?
I'm not specifically aware of booster data in the younger male population. And I think a part of that comes from the fact that it's only been just recent that even adolescents were able to get the booster vaccine. If you look at sort of that 16 to 17-year-old group, it's only been a little over a week in terms of patients who have been eligible for that vaccine. So I think certainly more information will become available. But I have a suspicion that the incidence will likely be similar with the booster dose as it was with the second dose, because that certainly proved true with other side effects in the adult population after the booster dose. But we simply don't know the answer, and I don't think there's sufficient data at this point to make a conclusion, but definitely more to come in the future.
Thank you.
Great. Thank you, Dr. Griffin. So there is a question from the community around whether there have been neurological tics seen in children under 18 for COVID-19 vaccinations or after the vaccinations and boosters. And for those that haven't seen the answer in the chat, we have not seen those reports yet. But if you do, please, we highly encourage everybody to report any adverse effects to VAERS. That's BAERS, and that URL, that link is in the chat there. The second question, and I will ask Dr. Tran to answer this question. The community asks, where are the best guidelines to follow for parents of newborns and young infants? Dr. Tran, you're on mute.
Sorry about that. I can certainly get the link out to everybody, but the AAP, the American Academy of Pediatrics, has a very detailed, comprehensive recommendation that you can certainly peruse and follow their recommendation. But just from my standpoint, just very briefly, because the vaccine is not yet quite available, so it's coming. The next one likely will be the 2 to 4-year-old, probably around March, and then very soon after that, down to the 6-month-old. And so probably early spring. So we're looking at a couple of months. But in the meantime, I think I would certainly follow the regular infection, the best practices in infection prevention, masking, hand hygienes, etc. And most importantly, though, I think if you have family that are eligible for the vaccine, I certainly would encourage the family members to get vaccinated. And that would certainly help protect the younger children that are not yet eligible for the vaccine.
Thank you. There are more questions coming in, and I'm trying to make sure I get myself organized. So there's another question. This is coming from the community as well. And this is more specific about scheduling of the vaccine. So for adults who received the J&J vaccine originally, then received a Moderna booster 6 months later, would these adults be considered fully vaccinated? And what's the recommendation coming from CDC for these adults? Maybe Dr. Nguyen, you can address this question.
Sure. So technically with the J&J vaccine, they're considered fully vaccinated after the first dose, but the booster itself actually will definitely increase the number of antibodies in your immune system, and they are considered fully vaccinated.
Fantastic. Thanks so much, Dr. Nguyen. The next question is for Dr. Hurley Kim. I'll ask you to answer this one. If I had COVID and got fully mRNA vaccinated, should I get a booster at this time?
This is a really interesting question. So there is some evidence that having a previous infection plus a primary vaccine series is highly protective, almost comparable to a primary series plus a booster. Although I will say that there is no specific CDC recommendation that I'm aware of at this time that says those patients should not receive a booster. So you are eligible for a booster, and it certainly may be recommended. It may be prudent to speak with your healthcare provider, regarding the exact timing of the infection and your vaccination. You would still be considered fully vaccinated with the 2 doses at this time, but a booster now or in the future may not be a bad idea as well.
Thank you.
We got some more questions here coming along, and I thought we should take some of these live ones. There's this question related to working in the lower income area, and there are people who are, I'm just trying to read this question. If they would like a COVID-19 vaccine and host a once weekly vaccine clinic at the pharmacy, is there anything you recommend in retail setting to help convince more patients to come in and get vaccinated? Maybe Dr. Hurley Kim, you want to take that one?
Sure, yeah. So I work with, I think probably a very similar patient population. I practice at a federally qualified health center here in Los Angeles, and we see the same thing where there's a lot of hesitancy and a lot of concern around the vaccines. And I think a lot of this we need to treat with a lot of empathy and compassion. I think the thing that I have found to be most effective is consistent but gentle messaging. So if a patient is not open to discussing the vaccination, don't push it. Wait till the next encounter and see when they may be ready to discuss at a later time. Also, having kind of neighborhood specific messengers can be really important. So if there are physician or pharmacists, kind of thought leaders, or even community leaders, religious organization leaders who can help to be your messengers, those things might be much more effective than a pharmacist who they may or may not be personally familiar with. So using the community contacts, and there's also some evidence that the more times you bring it up and the more different professionals who bring it up, the more accepting patients will be of vaccination. So it's more of thinking of it as a marathon rather than a sprint. It may take several encounters with that patient to help them to receive the vaccine, and whether that is available at a weekend clinic, it may or may not be the case, but just being gentle but consistent, I think, is the key.
Thank you. And then there's also another question coming from the community, and I thought that can be addressed by any of our participants. Someone mentioned that he or she has taken a dose of J&J vaccine back in March, and then the Pfizer booster in October. So I guess 7 months in between. Is that enough coverage based on current information that's available, or should that person obtain a regular 2-dose mRNA vaccine? Do we have any information? Anybody who wants to address that within the panel? Any thoughts?
Alex, can you ask the question again? What's the question?
Yeah,
again? I don't understand it.
So the community person had received a Pfizer dose. Oh, sorry, I apologize. So receiving the J&J vaccine back in March, and then a booster dose of Pfizer in October. So 7 months in between. Is that enough coverage at this point? Should that person, seek to receive a 2-dose mRNA vaccine course at this time?
I think right now that's the current recommendation after the J&J is to receive the 1 mRNA vaccination. I think in the future it may change, but currently that person's considered, fully vaccinated and boosted. And then the most interesting aspect is when they look at the previous studies, that's actually a great combination because the mRNA vaccine after J&J really pushes up those antibodies and is relatively strongly protective.
I agree. I think this science is, continually evolving. Let's put it this way. And there's some other questions here that are very general, but what are your recommendations in terms of choosing between the booster, and of course whether or not that there's a difference between Pfizer versus Moderna vaccines? Do we know enough at this point to say anything? Dr. Nguyen or Dr. Hurley Kim, what are your thoughts?
Go ahead, Lee. You probably
Go
have
ahead, Carrie.
Are you sure?
It's fine.
Okay.
Yeah.
So I think the most important thing is, if you are considering a booster, is to get a booster. If choosing one or the other means that it might delay receiving it, I don't think it's worth it to delay. If you have your choice, there is some data to suggest that mixing and matching, meaning if you were initially vaccinated with Pfizer, that a Moderna booster may provide a slightly higher immune response. Whether or not this is necessary or would provide a better protection against infection or a more long-lived immunity is kind of an open question, but I think it's worth mixing and matching if you have that option.
I was going to say something very similar, that recommended you should just get a booster. It's ideal. I think one of the things you have to think about is, in terms of mixing and matching, is there's not a strong downside. There is only upside in terms of improved, vaccine efficacy. But again, it's really just as soon as you can, when you hit that 6-month mark, to get boosted right away, especially coming into the holidays and the Christmas season.
I agree. I think the message here is not to delay the booster, and I think just go with what is available out there, which is, I think, an important message. And I think all the speakers has also sort of alluded to that the current vaccines are very safe. And of course, it's important that we still continue to practice, hand hygiene and other ways to protect ourselves of getting the virus. So stay out from crowds, make sure that you're well masked. I think those are the fundamentals that we should not forget.
That's right. Well, thank you so much, everyone. We want to thank our speakers for their expertise and their time in creating this, pulling this content together and delivering to the community. And we certainly appreciate the community for engaging with us to really listen in and ask the questions that you've asked. Thank you to UCI. We are, again, grateful for this collaboration, and we wish you all a happy holidays. Be safe.
Thank you. Happy
Thank you.
holidays.